Hello everybody, welcome to the first RheumRoom that we are live streaming today. I am Jack, I'm from Rheumatology.physio, and hopefully we're going to cover some good ground with regards to osteoarthritis in this stream today. So if somebody can just pop into the chat bar, I know there's a few people watching, so pop into the chat bar that you can hear and see me, that would be absolutely ideal. I don't really get any feedback using this mechanism as to whether anybody can hear or see me. So just give me a thumbs up or just let me know you're here, something like that. And then we'll crack on with some of the clinical content. Oh, excellent. So we've got Hannah, nice to see you, Hannah, and Francesca can see and hear us, so we're going to crack on with some questions. So hello Tamara as well. I've had a few questions that have been put in early doors from my social media posts that were out yesterday, so we're going to cover those first, and if anybody wants to pop any further questions into the chat bar or have any comments or anything like that, then please let me know. First thing that I'm going to get everybody to do is we're going to try and run these weekly to start with, certainly for the foreseeable future, every Tuesday at 8 p.m. my time. We'll see how they go. If it becomes too burdensome for everybody to keep up with, then maybe we'll slow them down a little bit, but we'll see. As long as the questions keep coming in, I will keep trying to answer them. So obviously tell all your friends, share it. If you think it's any good, then let me know. If you think it's rubbish, also let me know, and I'll try and do better next time. So first question I've got my very technical piece of paper here that I've got my questions written down on. So first question it came from Twitter, and it was from @thenewgirl000, and she asked, how do you explain OA to patients? Other professionals use wear and tear, bone and bone, and can blame activities such as running as the cause, and this can be very unhelpful when you try to encourage exercise and strengthening. And I thought it'd be a good question to start with, because the follow-up question that we've got in a minute follows on quite nicely from this. And osteoarthritis is a really difficult one to explain to patients. It's one of those conditions where you have to be honest. If you look at it on an x-ray, it is technically degradation of the joint. So the joint is not as good as it was at one point in the past. But what we need to do is get that across in a reassuring fashion, and make sure that the patients understand the exact processes, what's got them to this point, and what they can do to help, and why things like exercise, strengthening, running isn't bad for their joints. So if we start off by thinking about what the pathophysiology is of osteoarthritis, and obviously, if you go back in time, it was thought to be this sort of wear and tear scenario where the joints would rub on each other, or the bones would rub on the cartilage and wear that away, much like a car tire. And I think this is where the question is sitting, about, people using wear and tear and bone on bone. And certainly the degradation of the joint does have some bearing upon what is happening with regards to people's symptoms, but it's the changes we see on the x-ray are they're more an outcome of having osteoarthritis. So the current understanding of osteoarthritis is this low-grade inflammatory process, which for all intents and purposes is pretty normal. So if you imagine your joint goes through stages through every day where the inflammation goes up and down a little bit, and that keeps the joint fed, so that with sort of inflammatory proteins and that kind of thing within the joint fluid to keep everything healthy, and that turnover of cartilage and bone is normal. And as we age, our metabolism slows, and we get a little bit worse at doing that, for want of a better term. And what happens is that can lead the joint to deteriorate. Now, what happens is that people will have these joint changes at a greater or lesser speed depending upon their own individual circumstances. So we have to consider that there's quite a large genetic component to whether people will develop osteoarthritis of a joint. We have to consider their general health as well. So anything that increases their resting level of inflammation is going to cause them to have a faster process within the joint. So you can imagine if you take someone who has quite a lot of inflammatory issues, so they're obese, especially with abdominal fat, they smoke, maybe they're diabetic as well. that will increase their resting level of inflammation, which increases the normal level of synovitis around the joint. And then what then happens is that if you add on a particular genetic predisposition to getting osteoarthritis as well, then that's when you see these people who are in their 20s or 30s who have osteoarthritic joints already. And that can happen quite quickly. Now that's a relatively extreme example, but you can see how you might find some people would get into their 90s before getting any joint problems, or even never get it at all, and other people get it at a younger age. And it's important to remember that actually the level of activity is not very relevant to their joint degradation. So we know, for example, there are studies in runners and recreational runners, so anybody that's not an elite athlete running extreme mileage per week, there's no more likelihood to get X-ray changes, or osteoarthritic X-ray changes for those people, and actually they get less symptoms. So if you match them with their X-ray changes versus the sedentary people, they get less symptoms. So you see the same amount of X-ray change, but less amount of symptoms, if that makes sense as a distinction. So the way that I go on to explain that to a patient is that I say to them, look, we don't know within your individual circumstance exactly what it is to lead you to this point. We know that we may have an X-ray, for example. We know that your X-ray shows changes, but what we also know is that those changes are not sufficient enough to cause you pain all on their own. There are other things that are going to cause aggravated symptoms. So if that's the case, there are things that we can change to make sure that those symptoms decrease. And what I'll say to them is, you have this capsule around the outside of the joint, and what that does is it provides joint fluid, which keeps the joint lubricated, but it also provides all the nice stuff that cartilage needs to flourish. And then what happens is that capsule can become more active or less active depending on the rest of your circumstances. So if it's more active, then you would create more joint fluid, more of those inflammatory chemicals, and then that's not very good for the joint over the long term. But what is good for the joint is things like exercise. So what we will see in people with exercise, people who have higher levels of exercise, is that the quality of their cartilage can actually increase. So they can't increase the amount of cartilage that they have, but where it's thinned, that cartilage quality can improve. So if they then take on weight-bearing exercises, they can improve that cartilage that is left. So what we do then is that you sort of have to map it onto the individual patient, but you'd say, quite an easy one would be things like joint surgery. So if anybody's ever had joint surgery, especially in the knee, then that's quite a good predictor of going on to develop osteoarthritis. And it's a very easy way of explaining what happens. So you get this insult to the knee, which increases the inflammation around the area, or the inflammation, the synovitis around the joint. That, over a prolonged period of time, causes extra of those inflammatory chemicals around the joint and causes the potential degradation we see on X-ray. What then becomes really interesting is you obviously will see some people who have one terrible looking knee and one really good looking knee. And actually their really good looking knee is the very painful one. And that could be quite a nice way in. So I always make sure that I say to people, it really is irrelevant what their knee X-ray shows, or their MRI scan shows. It's all about what their symptoms are and can we modify those symptoms. So there is no reason why, and I think we use the term bone on bone, even if we used that term bone on bone from the X-ray, then there's no reason why they can't improve with the strengthening exercises, the cardiovascular exercises, the physiotherapy that we can provide them. So I don't dismiss the X-ray. I say, look, there are relevances to the X-ray, and actually if we come back in 6 months' time and we've not improved at all, then we might consider that the X-ray is severe enough to be causing you some more problems. But actually what we do know is that it doesn't matter at what stage your X-ray looks like. If you start these exercise programs, then we can go on to see some really good improvements. So it's really important to have that conversation with people, see if they can get a light bulb moment that actually we need to ignore to a certain degree the X-ray, because the problem with osteoarthritis is and I voice this to patients, is you've kind of got a bit of an all or nothing treatment program with them. We're seeing more and more that the injection side of things isn't very good for the joint and actually potentially speeds up their requirement for a knee replacement, even though symptomatically in the short term can be helpful. So they kind of have these two options. They either go full on for a knee replacement, which has its own risks, its own problems, especially in the younger patient, or they try the exercise program. The exercise programs, they're not a quick fix. So if they're there thinking I'm going to be better in a few weeks, that's not really going to happen, because what we've got to do with the exercise program is that we have to improve the whole conditioning of the system. It's not just the legs. So you take something like a strengthening exercise, and yes, that will offload the knee joint to a degree, especially something like the patellofemoral joint, but that's really not the mechanism that we're aiming to hit. What we're aiming for is an improved global ability to do things. So we want in better fitness, better tolerance. So we know that with exercise programs, people's central sensitization decreases, so they can tolerate more activity before they get a pain response. To simplify that down a little bit, but also we get sort of more self-efficacy, and with the exercise programs, obviously we can bring BMI down. So everything like that, all those factors, we're sort of waiting for those to kick in and start to improve things. So it isn't a quick fix, and it is something that we need to tell people is going to take time. And there's no way, I wouldn't sit in front of any patient who we thought osteoarthritis was the overriding diagnosis causing their symptoms and say that they're going to be tons better in a few weeks' time. It's going to be months, and they need to stick at this exercise program because it's a global change they're looking for, not a local change. So hopefully that's been helpful to explain sort of some of the differences there. I mean, yes, I would agree absolutely that using terms wear and tear is not entirely correct, and that has been shown to have detrimental psychological effects to patients when you tell them that. Bone on bone certainly not helpful at all either. Iatrogenic is the term that we would use. Not helpful at all. Try and use a reassuring type conversation with the patients, and hopefully that will get them on board in the same way with the exercise programs. If anybody's got any further questions on that, do please put them into the chat and we can come back to that. But hopefully that's given you some ideas as to how to discuss those things with patients. Certainly one of the things I always try not to do is be critical of previous healthcare professionals, and I've learned that along the way, and I've heard a lot of people say that before as well, is that there's no mileage for you as the current professional to say anything bad about the previous one. For one, that patient might have a really, really good rapport with the previous I've gone right out of my head what I was saying, with the previous professional, and you might ruin your own rapport by doing that. So I just say, this is how I explain it, this is how I explain it differently, and see whether that makes sense to them. And hopefully it does, and usually you can find a way of getting around that. And I always sort of talk a little bit about research and those kind of things. So the second follow-up question, which I thought fit into this quite nicely as a sort of follow-up, was from Jack Chu, who hopefully most people are aware of. And he said, and it's quite an interesting question really, where does OA end and RA begin in edge cases? So what he's meaning there is if you've got, if we consider osteoarthritis to be an inflammatory condition, and then we obviously take rheumatoid arthritis, which would be sort of your archetypal inflammatory arthritis, then where do you draw that line if they've got similar pathological processes? And there is some distinction that we can make, and there are some interesting points we can make there. So what I would say is that if you were to look at a 1,000-foot view, for example, then yes, the inflammatory system theoretically causes the osteoarthritis. So that low level increased inflammation within the body over an extended period of time. And if you take rheumatoid arthritis, you get a similar process. So you have a raised inflammatory process through the body for an extended period of time, and that causes damage to the joints. And both of rheumatoid arthritis and osteoarthritis, it's through synovitis that causes that problem over the long term. So what we then need to do is, with a distinction, we need to zoom in a little bit. So if you imagine that osteoarthritis, like we said, is caused by this general raising of inflammation within the bloodstream. So that's the initiating factor. So let's make it simple for ourselves, and let's say someone's got a high BMI, so they've got excess abdominal fat, and we know that that creates inflammatory cytokines that get released into the system. They're called adipokines, which is, I find, a interesting phrase, or interesting word, I should say. So it releases adipokines into the system, and that raises up your general inflammatory level in the blood. So your ESR, your erythrocyte sedimentation rate, for example, will be raised, and we can show that over extended periods of time. So if you take someone who has a normal BMI, then normal ESR will be somewhere around 16 to 20, whereas someone with a higher BMI, a BMI of over 30, their ESR can sit at a normal range of 26. So it is quite a significant raise there. So we know that happens. So what then happens is that those inflammatory cytokines will eventually start to affect the joints, just like they do with multiple other systems. So they affect the cardiovascular system. You end up with more risk of heart attacks, strokes, all these kind of things. We know that being overweight, obese is a risk for having cancers, certain types of cancers. So all sorts of things happen, and the fact that it affects the joints is not a giant surprise. So we're talking of an instigating factor of that general level of inflammation. Now, if we talk about rheumatoid arthritis, then what we see is that the initiating factor is that the immune system itself is causing that raised inflammation. So the immune system is not recognizing the synovial cells as part of you, and starts, for want of a better term, to attack those cells and causes the inflammation. So you've got a more direct cause of the inflammatory problem. So you get more of an acute type synovitis. So what you then have is this distinction where you would see in rheumatoid arthritic patients, you would see quite hot, red, swollen joints, and also a component of tenosynovitis as well, which is what causes the stiffness, the hand stiffness or the foot stiffness, joint stiffness. And that is then protracted. So because the immune system is causing that reaction, that causes a protracted stiffness, especially in the morning, joint stiffness, especially in the morning or especially after rest. Whereas osteoarthritis, because it's general, you don't get that protracted stiffness. So it's quite a good way of differentiating. The other thing that we'll tend to see is the location of the joints affected. So in osteoarthritis, you tend to get the big toe, the knee, the hip, and the CMC joint of the thumb are the most likely affected locations, whereas in rheumatoid arthritis, the MCP joints and the MTP joints are the most likely affected, with the knees and ankles coming sort of relatively quickly after that. So a bit of distinction there as well, but really it's eventually what you get is, if you consider that everybody's immune system is slightly different, and you have your own unique immune system, you will get some people who have osteoarthritis that blur to look like a rheumatoid arthritic pattern, and you will get some rheumatoid arthritic patients that blur to look like an osteoarthritic pattern. And we do have to consider that patients will come with their own sort of unique set of symptoms. So it's those real fringe cases where you get some odd ones, we're probably going to find that that's a little bit more difficult. And what we would then, or what the rheumatologists, for example, would do is you base it upon blood tests, and you base it on imaging changes, on ultrasound, usually, like I say, to find tenosynovitis. So there would be some changes there, which we will probably see to distinguish out what those patients have. So if you've got someone in clinic, then really you can do some differentiation with family history. So family history of rheumatoid arthritis is a bit predictive of going on to develop it, but also that protracted early morning stiffness, so early morning stiffness lasting longer than 30 minutes, or stiffness that deteriorates after resting. But also waking in the night as well. So if patients wake in the night, they will often have quite specific patterns to their night waking with rheumatoid arthritis and the other inflammatory conditions. So they'll tend to wake in the second half of the night, and they'll tend to have to do exercise to try and loosen their joints off. Whereas with osteoarthritic patients, that doesn't tend to happen quite so much. So there is some ways you can differentiate that in clinic, and I can see that Jack is giving me an okay sign to say that I've answered his question reasonably. But I do think that what we do need to remember is that those patients will blur on occasion. We should, when we're seeing patients in clinic, we obviously need to ask them all about their past medical history, and that's probably outside of today's webinar's distinction, but there is a lot of things we can do with regards to differential diagnosis, because what we need to remember as well is that other conditions, especially rheumatology conditions, when we're talking about joints being affected, can look a little bit like osteoarthritis or rheumatoid arthritis. So it's one of those things where you might think, okay, they don't have symptoms that are suggestive of a rheumatoid arthritic pattern, so I'll call it osteoarthritis. But what you're actually doing is you're missing another key variable that then you would go on to say, actually, they do have a rheumatology problem, just not the rheumatology problem that I thought. So hopefully that answers Jack's question about fringe osteoarthritic patients. It's a difficult one to answer. I had a very similar question from David Poulter as well around osteoarthritis, and one of the things that I do want to sort of say about osteoarthritis is that, you know, I think we're getting towards the stage of saying it is more of a metabolic problem than it is to be a physical wear problem. It's definitely something to do with that. We do see there are some locations, like for example, like I said, the CMC joint. It's not a high load. If you imagine the load that's going through your knee versus the load that's going through your CMC joint, they're not equal, and yet CMC is the third most likely location to see osteoarthritis. So we are moving towards that as a metabolic issue, and this is why general health is so important with regards to people's function. They need to stay generally healthy to reduce their risk of osteoarthritis, and things like smoking obviously is detrimental towards that as well. So basically with the same treatment patterns, we're then obviously going to treat them quite generally with general health advice, general exercise advice. There's nothing to stop you at all doing specific exercises for the joint affected. So like we said, there is evidence to show that the cartilage quality will improve if you exercise the joint. But equally, if they're really struggling with severe pain, then exercising other joints as well. So you might do a lower load through, let's say it's osteoarthritic, you might do a lower load exercise program for the knee, but then you might do higher load exercise programs upper limb to try and get that cardiovascular element, the general health element, alongside dietary advice, smoking cessation, all those kind of things. So hopefully that's answered those questions appropriately for you. I'm just wondering if anybody does have any questions that they want to jot down into the chat, and we will go ahead and answer those, and then see where we get to. Just while I'm waiting for any questions to come in, I do want to direct you to if you don't mind following the or subscribing, I should say, to the YouTube channel, and then that will notify you of any new videos that I put up. And I will try and do, like I said, these live videos once a week at the moment. And I am going to do, if I get other questions through social media, I'm going to try and answer one a day, sort of on a live stream on Twitter or Instagram as well. And then what I'm going to do is combine those videos to a YouTube video at the end of the week, so that we, because they only stay up for 24 hours, so I'm going to merge them together, so we'll get a few more learning opportunities as well. I'll try and tag them somehow to people who have asked them. I do follow my social media pages as well, and then everything else that I tweet out about rheumatology based things, you will see. Tamara says thank you, that will be very helpful. No worries, Tamara, I hope you enjoyed it, and hopefully everybody else has as well. If there aren't any further questions forthcoming, then we will end the live stream in a minute. Next week we will have a slightly different overarching topic, so I'll put that out over social media as to exactly what that's going to be. I need to collate all the questions. I've had loads of them, so I do need to get it. We've got one in late from Peter Burns. Does the threshold for offering bone protection medication change when someone has RA, SPA, OA, regardless of age and risk factors? So Peter, the threshold for offering bone protection medication doesn't change when someone has those types of arthritis. It's purely based upon, so the score I use is a FRAX score, F-R-A-X, which you can find on Google, which you plug their score into, and what they do is they're just general questions like age, sex, family history of hip fracture. And that will give you a score as to what you should do with them. It comes up in 3 different colours. Green is just lifestyle advice, yellow is a DEXA scan, and red would be to start treating with bone protection. So with the FRAX score, it does allow you to put rheumatoid arthritis as a risk factor in. So that's the one that I use, and I just replace that with rheumatoid arthritis and spondyloarthritis because they are risk factors. Osteoarthritis, as I understand it, is not, although as we discussed, they could have other general health risk factors associated with that. So it's something to do, but based on screening would be the bone protection. Hopefully that answers that question for you, Peter. Tamara's jotted in another question here. Is it essential to do certain blood tests in primary care prior to considering a rheumatology specialist? No, is the answer to that, Tamara. In most cases, I actually advocate for not doing the blood tests, and that's because there are a certain proportion of patients that will come up negative. And you have to be aware of the local referral guidelines, which the guidelines for getting into certain departments, and sometimes they will not take referrals if certain blood tests are negative, whereas unfortunately there are some patients who will have negative blood results and still have a rheumatological condition. So it depends on your local pathways, but I would say no, certainly to that question, it's certainly not essential to do blood tests in primary care. And one of the issues I always have with ordering the blood tests for rheumatological conditions is that we aren't rheumatologists, and the issue becomes when we've got a masquerading condition. So for example, I did this absolutely did this to a T. I had a patient who I was in my rheumatology clinic who I thought had barn door rheumatoid arthritis. It turned out they had lupus. So when I'd done the blood tests, they came back negative, but they saw the rheumatologist anyway, because I referred them into the rheumatologist, and they did lupus-related blood tests and they came back positive. So it's something that's much more complex, and we shouldn't feel bad if we are certainly out of our depth with regards to some of the more complicated blood testing. Faye says, what kind of questioning do you recommend to particularly help to guide your treatment and management plan in the case of OA? So certainly the level of someone's symptoms, so on a VAS scale, the higher that is, the less aggressive I would be with their exercise program, but also the reactivity of their symptoms as well. So if they react really strongly, then I'll take a softly approach, but otherwise if they're quite non-reactive, then I push them really quite hard. So the usual my usual go-to would be a VAS of about 5 or 6. I wouldn't really be pushing someone much past that, and I would want their symptoms to resolve back to normal within 24 hours. No worries, Peter. I'm glad I answered that question for you. And same to you, Tamara. And then Catherine says, what advice do you give regarding joint protection in rheumatoid arthritis? Do rheumatoid arthritis joints respond well to specific intervention, or is medication the main intervention? Okay, what I might have to do, Catherine, is I'll answer that question in a specific webinar, because that's quite a lot to go over in this. So what I'll do is I'll tell you what we'll do next week. Next Tuesday we'll do rheumatoid arthritis, and I'll put that question at the top of the list. Okay, I was going to aim for about 30 minutes, and we're at 29 at the minute, so I'll take one more very quick question if someone's got one. Faye says, thank you. No worries, Faye. I'm glad you found that useful. Okay, no worries. So like I say, for everybody, if you don't mind subscribing to the channel, and I'll be back same time next week. So it'll be 8 p.m. British Standard Time next week, next Tuesday, unless something catastrophically goes wrong, but hopefully not. I seem to have got the technology working this time around, so fingers crossed I can keep managing to do that. Like I say, we'll do rheumatoid arthritis next week. Do find me on social media at PhysioJack on Twitter, and Rheumatology. I've just forgotten what my Instagram handle is. Rheumatology.physio, I think I am on Instagram. So you can find me there. And like I say, I'll do some little questions that I've had already through on live streams there and create those into one video at the end of the week. So thank you everybody for joining in and watching. If you didn't ask a question, thank you for joining. If you did, thank you very much, especially to Tamara and Faye and Catherine, whose question I'll answer next week, and Chewy, of course, and Hannah, who right at the beginning of the show said that we were ready to go, and hopefully you've all enjoyed it, and we can do this again next week. I'll see you then.